Thank you, Selena. I'm honoured to be here today representing Amgen. I hope I didn't offend you. We're saying, perfection. Sometimes we can paralyse ourselves in perfection. I'm just glad to be here today. Amgen's mission is simple but powerful. We serve patients. And we have a bold ambition to reduce cardiovascular events by 50% by 2030. And this isn't just a goal, it's a movement. And why does this matter? Because nearly 48 million women in the US are affected by cardiovascular disease. 48 million women. That's mothers, daughters, sisters, and friends. Yet too often, women's heart health is overlooked, it's underdiagnosed, and it's undertreated. And that's why we are so proud to partner with WomenHeart and be here today, because to take action, you first have to know something. And one of the most powerful ways to start taking care of your heart health is to know your numbers. Specifically, your LDL-C, otherwise known as bad cholesterol, and Lp(a) levels. These are critical indicators of heart disease risk, and today we're going to make it easy for you to take that first step. In your red bags of courage, you'll find a postcard that looks like this. Scan it, fill out the form, and you'll receive a free LDL-C and Lp(a) test delivered to your home, a simple finger prick. You can also share the QR code with your friends, your family, and your fellow sisters. Because heart health isn't just personal, it's generational. Heart health is women's health. Now, I'm honoured to introduce an incredible discussion, Women, Heart and Disease Across the Lifespan. This panel features some of the most outstanding voices in the field. Dr. Rachel Bond of Dignity Health, Dr. Erin Ferranti, incoming president of the Preventive Cardiovascular Nurses Association, Claire Gill of the National Menopause Foundation, and Dr. Charity Watkins, an amazing Women Heart champion. A special thank you to you, Beth, of HealthyWomen, for moderating today's discussion. And of course, a heartfelt thank you, Jodie and WomenHeart, for making this event possible. Amgen is proud to stand with you in this fight against heart disease in women, because together we can make a lasting impact. Let's get started.
So I am super excited to welcome our panelists, and I'd like to invite each of our panelists to introduce themselves and kick us off with your reflection on the first question, which is, tell us about the work that you're doing at the intersection of heart disease and women's health. And as you think about the answers, think about key health issues that women are facing, especially during critical transitions of women's lives. The start of our period, pregnancy, menopause, postmenopause. So, Dr. Rachel Bond, I'm going to start with you.
Yes, thank you so much for this opportunity. So my name is Dr. Rachel Bond. I am a preventive cardiologist currently in Arizona. I work at Dignity Health, where I'm the system director for the Women's Cardiovascular Program. I dedicated the majority of my career really to honing in on women's cardiovascular health when I was even as a resident seeing that there were so many disparities. And for me, the focus has largely been on specifically women of color who have the greatest disparities. When I was asked to participate in this panel, it was something I was so passionate about because a lot of my work really has been focusing on the lifespan approach. When we hear about cardiovascular disease, we always hear about these staggering statistics, and yes, they are staggering. But the good part of it is as we all probably know in this room, it's preventable 80% of the time. So for me as a preventative cardiologist, I wanted to really focus in on that preventative piece. And we know that the prevention aspect of it comes that when we educate these women that were once young girls as early as possible. When we look actually at the statistics, we see that it's the group specifically in those reproductive years between the ages of 35 to 54 who are having the highest rates of death from cardiac disease. And unfortunately, it's occurring at younger and younger ages. So for me, this is where a big component of my research has been focusing. I also volunteer quite a bit with many of our national cardiovascular societies, including the American Heart Association, the American College of Cardiology, and the one I'm most proud of, which is the Association of Black Cardiologists. And one of our campaigns, which is honing in on these reproductive years, really talks quite a bit about how educating as early as possible the youth, also incorporating these social determinants of health, these negative social determinants of health, how that's going to hopefully make a difference, and we know the data demonstrates that it will. One area with the ABC, or the Association of Black Cardiologists, and for those in the audience that are not familiar, this is a nonprofit organization that just celebrated their 50th anniversary. They're doing amazing, amazing work for the Black and Brown community as well as other marginalized groups. One key area that we've been targeting is the Black maternal health crisis, just because there is such an intersection between what happens during pregnancy and what can also lead to cardiovascular outcomes. We created a campaign called We Are the Faces of Black Maternal Health, and that campaign not only highlights what's happening to the health of the woman while pregnant, but also their offspring, what impact that leads to them in the future, and how a lot of that, again, salient information that we provide to our female patients also should be provided to their children, but their pediatricians, so that way they're targeting their health probably as early as possible. So I'm so fortunate to be here, and in answering your question, I would say that as women, we're going to be experiencing all these different chapters in our life. Some may decide to have children, some may not, but all will be going through hormonal changes, be it at the start of their menstrual cycles or at the end of their menstrual cycles. And all of these lead to actual stress, and there is an interconnection between those stressors, those hormonal changes, as well as cardiovascular disease. So the fact that we're having this conversation right now is so encouraging, because this is really what's going to make the difference in targeting, again, that 35 to 54-year-old female who's having that highest risk of death. So I'm excited for this conversation. Thank you.
Thank you so much. So I'm going to jump around a little bit because I'm going to get confused, so just bear with me. So Erin, I'm going to go next to you. Sure. If you can introduce yourself, and again, tell us about the work you're doing at the intersection of heart disease and women's health, and some key health issues that women are facing, especially during critical transition periods.
Yeah, thank you. So yes, I'm Erin Ferranti. I'm an assistant professor of nursing at Emory University in Atlanta. So I have the privilege of working with Dr. Wanger in Atlanta, so such a joy. I'm a public health nurse by background, so I come to this probably at a little different angle, and always have been interested in prevention. And I live in a state where the maternal mortality rates are higher than almost any other state in the nation, and we have incredible health disparities. So for Black women in Georgia, cardiovascular disease is the #1 killer for maternal health, and I just couldn't be okay with that. And so as a public health nurse, I sat on the Maternal Mortality Review Committee and, watched and read, these cases of women who are dying by cardiovascular disease. Nearly 100% of the cardiovascular cases are preventable. And so when we look at reproductive age women, it's not a target population we have traditionally focused on in cardiovascular health. And, we do a wonderful job of taking care of women during pregnancy because we want those outcomes to be okay for a baby. And I feel like women fall off the cliff after delivery and that nobody's really paying attention to them. And, less than 50% of women come into pregnancy at optimal cardiovascular health, so we know we're dealing with a high-risk population. So my work largely focuses in the postnatal timeframe for women who've had these cardiovascular risk factors, but recognizing that women come into pregnancy, suboptimal cardiovascular health, I've now been focusing on the prevention and pre-conception focus, and largely focused in rural health. So Georgia is very much a rural state. Yes, we live in Atlanta, and it's a big metro area, but a lot of our disparities are in the rural areas, and so that's where my focus has been.
That's great. Thank you so much, Erin. And Claire, I'm going to jump to you. Tell us about the great work that you all are doing at your amazing organization.
Thank you. I'm Claire Gill. I'm the founder and president of the National Menopause Foundation. This is my passion project. My day job is I'm the CEO of the Bone Health and Osteoporosis Foundation. So I founded the National Menopause Foundation at the end of 2019 when I realized there was no patient advocacy organization dedicated to women at menopause. 2019, ladies, that's kind of crazy. I share that I was recruited at one point in my career by Save the Bats. So there was a national organization to save bats before there was an organization focused on women at menopause. Kind of why we're all here today, right? We need to reprioritize this. I'm really delighted to be part of this conversation about all the inflection points within a woman's journey, health journey, where cardiovascular disease becomes very important. And it really is a lifelong journey to continue to keep our hearts healthy. At menopause, women have an increased risk of developing cardiovascular disease. And so at the National Menopause Foundation, we work to not only address the symptoms of menopause, and there are plenty, but also to talk about things that women need to know about their increased risk for cardiovascular disease, for osteoporosis, coincidentally, and for breast cancer. And so I think it's really important that we make sure that women know what to expect as they approach midlife and as they journey through menopause and into their postmenopausal years. Now that we're all living longer, yay, we will spend about 1/3 of our lives postmenopausal. That's a long time. Yeah, thank you. That's great, right? And so we want that to be as healthy as possible, and I think it's conversations like we're having today that will help us address how do we reach women and let them know all of the things they need to know, not only about the menopausal journey, but also about how they can continue to keep themselves healthy throughout the rest of their lives.
Thank you so much, Claire. And Charity.
Good morning, everyone. Jody knows I am a historically black university professor. So when I say good morning, I'm expecting you all to say good morning back, okay? You ready? Good morning. Good morning. See, I knew y'all could do it. My name is Dr. Charity Watkins, and I'm an assistant professor of social work at North Carolina Central University. I'm also an adjunct assistant professor at Duke University in the School of Medicine in the Department of Obstetrics and Gynecology, where I am a Building Interdisciplinary Research Careers in Women's Health, or BIRCH, scholar, which is an NIH-funded career development award, where I am conducting a study to explore and expand the role of social workers in maternal health, especially around interrupting racial bias and structural racism that impacts the outcomes, the poor outcomes that we see for Black and brown mothers, especially around the issue of severe maternal morbidity. Now, my research is directly informed by my own personal experience of being diagnosed late with peripartum cardiomyopathy, which is pregnancy-related heart failure. It was now almost 9 years ago when I was diagnosed. And I was diagnosed during that very critical period of time that Erin was just talking about, after the 6-week mark. I was diagnosed after first seeing a provider and being told that I had the flu. And then I was told that I had postpartum depression. And it wasn't until I went to campus health, because I was a PhD student at that time, where I was finally heard and was examined, and then had an x-ray that showed that my heart was enlarged, and eventually was admitted later on that evening into the cardiac intensive care unit, where I was told my heart was functioning only around 5%. And so I became very close to becoming a part of that statistic of maternal mortality, but luckily now I'm able to sit and advocate in this space of severe maternal morbidity. I do this with a number of different hats, including being a professor and researcher, but I'm also a community advocate. I am the board of directors chair for a nonprofit based in Durham called Equity Before Birth, which seeks to address the social drivers of health that are affecting Black women and brown women and birthing people all together, in order to see how we can combine social justice with birth justice. I look at this issue both professionally as well as personally. Personally, I have to think about the fact that as a WomenHeart champion, I joined in 2019, and I was a proud member, and I still am, of WomenHeart. But I also, during that year, later on in December, experienced a significant loss, and it is related to women's heart health. My mom, who had heart failure, suddenly passed away in December, just a few months after becoming a WomenHeart champion. And I later on learned, again, intergenerational aspects of women's heart health, learned that my daughter has the same genetic trait that contributes to a weakened heart muscle as I do. And so she's already seeing a cardiologist at the age of 8. So we're talking about 3 generations impacted by women's heart health or health disparities faced by Black women. And I really want to focus on how stress and race-related stress contributes to these outcomes for Black women, and how we can really alleviate that stress in order for us to support the health of Black women and all women.
Thank you so much, Charity, and thank you so much for sharing your personal story. So we're going to go into the debunk of misperception. What common misperceptions about heart health do you want to debunk here and now? And the second part of the question is from the patient's perspective and then from a provider perspective. So Dr. Bond, I'm going to start with you.
Well, I think the biggest one, which all could probably in this room attest to, is that heart disease is a male's disease. We obviously know that it's not. Unfortunately, all of our research, at least back previously when we were looking at these larger clinical trials, did focus on that aspect, and really, as a result of it, had women be perceived as little men. I'm encouraged, though, by the fact that now we see that there has been a change in where our focus of research should be. As an example, we have more and more women cardiovascular centers, like ones that I oversee, popping up around the United States and all across the country and the world. As such, there's research that's focusing on female-specific risk factors, including menopause and the reproductive years and pregnancy, as well as stress, as you mentioned, because for me, a big component of that research has been that intersection of that sort of the lived experience and what does that do to our cardiovascular system. As you could imagine, those lived experiences of being women of color or marginalized women from either the misogyny or the discrimination that we encounter, that's going to release a lot of those stress hormones, and that's going to increase your risk of having heart-related issues, even some cognitive issues earlier on than somebody who may not encounter that. So I'm encouraged by the fact that we're having a lot more research that's honing in on that, but I think that the greatest myth is that we have to remain focused on the fact that heart disease is impacting women just as much as it is men, if not possibly more, because of those unique risk factors. And then your second question.
The second question is from the patient perspective and then from a provider perspective.
Well, I think from a patient perspective, just as we heard, and thank you so much for sharing your story. I think more and more of us have to hear stories like yours. From a patient perspective, a lot of this is called medical gaslighting, right? We know that when you go and you know there's something going on with your body and you're told, it's the flu, which, by the way, is not very benign, or you're told that it's stress, it's because you just had a baby. Well, you know that there's something going on with your body, and that's not probably related to just the pregnancy itself or just being a mother that's tired, that there's something else going on. From a patient perspective, it's being comfortable with advocating for yourself and also being comfortable in realizing you can have a second opinion or a third opinion or a fourth opinion until you find that one person who's willing to listen to you. And although I know that the journey sometimes it's hard to find that clinician, that physician that you feel comfortable with, Organizations like WomenHeart sometimes make it easier because there are directories out there that help you realize that there are cardiologists out there, physicians out there who focus in on women's health. From a clinician perspective and a physician perspective, I think that we often have to do a better job in listening to our patients as well. I think that there is a myth also, though, that we as physicians may not necessarily always listen to our patients, and I know that there are physicians out there that do. It's just sometimes the challenges of the healthcare system that makes it harder to actually listen. And this is why, for me, I would say I'm a big advocate of the team approach to care as well, where we have the physician working with the nurses and the nurse practitioners and the advanced practice providers and social workers and every member of the team, because at least one member in that team is going to hear what we should hear, and it's going to make the biggest difference. So I would say that that's probably, for me, the biggest myth, but also the biggest benefit that we can leave here today with is realizing that let's advocate for ourselves, let's do better in listening, but also let's work together as a team to help with that earlier diagnosis.
I love it, and I love the fact that over communication on if you don't feel comfortable with the healthcare professional, the doctor that you're with, seeking a second or a third opinion is so important. I think that needs to continue to be over communicated, and that team approach is working. So thank you for your response. And Claire, I'm going to go over to you. Again, looking at what common misperceptions about heart health do you want to debunk here and now? And then the second part of the question is from a patient's perspective and then from a provider perspective.
So I think one of the myths, I guess, is that menopause causes cardiovascular disease. So I think that's something that women tend to think, and so it's really important that we realize that it does not cause cardiovascular disease, it increases our risk for cardiovascular disease. And then from a clinical perspective, I think, at least well, you're an example of it, is that cardiovascular disease only happens to older women. Right? And so being aware that women across the lifespan, 8-year-olds, might need to be concentrating on their heart health as well. So those are two big things. And the one concern I have, just when we talk about getting the multiple opinions kind of stuff, it's a little bit like in menopause too, where some people say, we tend to say, if you're not comfortable with your doctor, go get another one. But I think about my small community in upstate New York, there was one gynecologist. There's no one else to go to. And so I think when we think about rural health and stuff like that, we need to be cognizant of that, and we need to come up with another opportunity. It is advocating for yourself. It absolutely is advocating for yourself. But what do we tell women when there isn't another person within their network, within their community to go to? So I'm not quite sure how to address that, but I'd love that to be something we all think about.
Yeah, and I think that's where innovation in digital health comes into play, where it provides more access. But I agree with you, and coming from upstate New York, I know exactly what you mean. Yeah. So now we're going to go to Charity. Charity, again, what are the common misperceptions about heart health do you want to debunk here and now, and from the patient's perspective, and then from the provider's perspective?
Sure. I'm actually going to reiterate what Claire just said in terms of age, that cardiovascular disease is something that only affects older people. I was 30 years old when I was diagnosed with my cardiovascular condition. And I remember being in cardiac rehab, and everyone was at least double my age. I did not see anyone who looked like me, and everyone was looking at me like, what are you doing here? And I'm like, yeah, what am I doing here? And it wasn't until I came to WomenHeart that I saw a range of women with a lot of different experiences, a lot of different age groups. I saw the intersectionality of heart disease here. And so I wanted to be very clear that this is not something that we can wait on until you're older to address, but actually we need to think about it more in a preventative manner very early on. And professionally, I really want to debunk the fact that heart disease is not something that is caused by just individual factors. It's not just about whether you eat well or whether you exercise or whether you are, getting that good old wholesome foods, all of that. It's about systemic issues too. It's about what kind of healthcare you have available to you. It's about what kind of stressors in your environment are contributing to you having higher rates of cortisol levels and cardiovascular risk. It's about your family history and how you're able to convey that history. Many of us don't know what our family histories are in terms of heart health. So I really want us to kind of debunk the fact that it's not just something you can change on an individual level, but it requires a systemic view. Thank
you so much. And Erin, over to you.
Yeah, well, everything that's been said so far is everything I agree with. The only other thing I would add is that we need to change our healthcare system to be more focused on prevention and management rather than because it's not that it's too late, but when you're as sick as you were, that shouldn't happen. We should have been addressing this way earlier and recognizing it way earlier. So we just need a different model. And I agree with you in terms of health education doesn't necessarily equal health behavior change. We recognize that. We all know what we should be doing, eating and exercising. But when I work with the low-resource, low-income women that I work with, it doesn't matter how much she knows about what a healthy diet is. If she's struggling to feed her kids, if she's working 3 jobs, she's not going to be making that gourmet, healthy plate meal. So recognizing the social determinants of health and really addressing those is the key to addressing all chronic disease, not just cardiovascular health.
Well said. Thank you, Erin. So now we're going to look at changing the landscape. So clearing up misperceptions is one of our goals here today. So what have you seen, or how have you seen the landscape changing at the intersection of heart disease and what has traditionally been called women's health? So who wants to?
Okay, I will take it.
Okay.
I think we sort of alluded to how the landscape has changed. I think the fact now that we're realizing that there are more risk factors that are specific for women during different periods in their life, be it, we haven't really listed every single one. However, be it when we're first journeying into womanhood, where there may be hormonal changes and conditions like polycystic ovarian syndrome may sort of come about, or let's say if a woman decides to have a child and they encounter an adverse pregnancy outcome like gestational diabetes or hypertension or preeclampsia, or again, that next chapter where they're now journeying into menopause and the effects of that when it comes to the depletion of the hormones and the changes that has on their cholesterol levels and the hardening of, or the stiffening, I should say, of their vessels and the changes in their blood pressure. So I think the fact now is we're actually discussing these risk factors, and as such, we're targeting our research specific to it. Another thing that's valuable is that a lot of our research right now is trying to put it in the perspective of the patient. And I think that the qualitative research makes the biggest difference, where we center it around the patient and we think about how this research is going to actually not just necessarily lead to better outcomes in terms of mortality, but also quality of life. As it stands, the majority of our research trials really do hone in on more of that mortality, saving a life, not saving a life, which is of course important, but we want to make sure that if we're living a long life, we have a good quality of it, right? And I think that's where the patient's voice makes the biggest difference. And I'm excited as it stands from the cardiovascular perspective that we're now thinking about all of those unique risk factors, but also, again, incorporating the patient into that discussion.
Love that. Thank you so much. Claire, I'm going to go over to you. How have you seen the landscape changing at the intersection of heart disease and what has traditionally been called women's health? Oh, all right. Let's go. All right, go ahead. And then I've got another question for you.
Well, thank
right
you,
after
Claire.
that.
I appreciate that. I actually wanted to build on what Rachel was saying in terms of that patient perspective and having patients at the table. I think that is very important because we can do a lot of assumptions, and we can use some of these tools in order to kind of make a summation of what patients are feeling and experiencing, but it's totally different to hear it directly from the patient. And so we need to make sure that we are seeing patients as equal partners and treating them as such. Your experience is expertise, and therefore it should be treated as expertise. You don't ask someone with who's board certified to just come and volunteer their time all the time. But if you have a patient who has a unique story and a unique perspective to share, pay them. Back that ask up, okay? I did say the K. Back that ask up. So that means if you're going to ask a patient to share their perspective, then show that you value it.
Love it, love it. And stay right there with your mic, because I want to ask you, has your care evolved? And how has been a Women's Heart champion helped you get the care that you're seeking?
Oh, it's helped me and it's helped my family. So WomenHeart has provided me with the language that I need in order to show that I am an expert in my own health. And so if I'm an expert, I'm expecting you to come to the table as an expert as well with my treatment. And so my cardiologist has been amazing. She actually was the cardiologist I saw when I was admitted into the hospital for those 2 weeks after giving birth. And we have an amazing relationship. She listens to me. She spends plenty of time talking to me. She knows my family. But then she also educates me on what I should be seeing and what I shouldn't be seeing. And then I'm able to take that information to my dad, who also has heart failure, and talk to his doctors and say, hey, why are you doing this? Why aren't you, how did you get to that decision? What kind of differential diagnosis processes did you engage in order to come up with that decision? And it has made a difference. I just did this 2 weeks ago when my dad was in the hospital, and I had to correct a physician who I heard over the phone was getting a little agitated with my dad because my dad was confused about what the care was he was provided. And I had to get on the phone and say, hey, what's going on here? And he ended up apologizing to my dad. But I had to advocate from 12 hours away for my dad's heart health as well. So this is information that I've gained from this organization that has had ripple effects within my family and my community.
Thank you so much for sharing that. So now, Claire, I'm going to go back to you. How have you seen the landscape changing at the intersection of heart disease and what has traditionally been called women's health?
I think I'm excited and see a lot of opportunity in the fact that we're talking about menopause more. When I think about my mom's generation, nothing, right? You kept it quiet. You weren't allowed to talk about it. Now we have celebrities shouting about it on Capitol Hill. I'm cool with that. Bring it. Like, we need everyone talking about it. And so I think for us, one of the important aspects is, though, to raise awareness about the symptoms of menopause. And there is so much education to be done. So much education from health professionals and the consumers and women. But we also need to talk about beyond the symptoms, right? We really do need to focus on, this is a journey, these are the things, the symptoms will end, here's what you need to do, and here's how you can address that. And help educate women to arm them to be better advocates so that they know how to have that conversation with their providers and try to find people with it. And I spent a whole lot of time, we were talking about, rural health and not being able, we know what to do, but we don't, they don't do it because they're busy working. Those of us who know what to do and sit up here on a stage talking to you about it aren't doing it either, right? So I spent a lot of time saying, do as I say, not as I do. It's a struggle for all of us, and I think women need to understand that and be supportive of one another and talk through what are the things that we can do to uplift everyone on this journey so that we all get the best care that we can.
Thank you so much, Claire, and well said. So, Erin, again, how have you seen the landscape changing at the intersection of heart disease and what has traditionally been called women's health?
Yeah, it's a great question. I think traditionally women's health has been OB-GYN care, right? I mean,
100%.
So it's all about menstruation and pregnancy, and we didn't even talk about menopause. And And when I work with women and I find they don't even have a family health practitioner, provider. They seek their primary care from their OB-GYN. And so that, cross-team care and really getting the OB-GYNs to work with family medicine and cardiology. And so I see that shift happening, and I'm really pleased to see it, and really advocating for women to have that constant provider, that it's not just OB-GYN care. So we're moving in good directions, but we have a long way to go.
I think we are too, so thank you for sharing that. Dr. Bond, what opportunity do you see to improve how we are addressing women's heart health care in the urban setting, rural setting, and for those who are underinsured and uninsured?
Yeah, well, that's a really challenging question to answer, especially in such a short time frame. What I will say, though, is I think talking about those disparities are going to help us to at least acknowledge that they're there and they exist. As mentioned, a lot of times when we're dealing with these under-resourced areas of the country, there may just be that one physician or that one clinician in the area that you don't have the opportunity to seek that second or third or fourth opinion. But that's where, as you alluded to, digital health may play a role. Obviously, we have to think about the limitations, sometimes a broadband service, but for the vast majority of people, even in those rural locations, access to internet is something that allows more accessibility. I can speak a little bit on rural health because even where I'm currently residing in Arizona, we have a large population in the rural communities, particularly the indigenous population, and they don't have access to cardiologists, let alone cardiologists like myself that focus in on high-risk pregnancies and women's cardiovascular health. This is where digital health has really helped to kind of bridge that gap, and we've been working with a lot of the local tribes to help to kind of provide that resource, and a big part of that is going to the communities and educating the communities as well. So it's one thing to say that, well, you can gain access to me, but you need to ensure that there's a level of trust as well. So that's where a lot of the work with the local clinicians and the physicians and the healthcare systems comes into the mix, because it's going into the communities, providing that education, but then also allowing them to understand that if they don't have immediate access to these specialists, here is an accessible person that you hopefully have trust in because they made the effort to go in and introduce themselves and answer your questions. And I think that for us, that's going to probably make the biggest difference while we are working on making some changes to this really amazing healthcare system, not that we're a part of.
So Claire, what makes you optimistic about the future of cardiovascular care for women at key transition times?
So I am optimistic about the focus on women's health research that was launched under the last administration. It was long overdue, and it was really great to see that come to fruition in so many ways. And I'm hopeful that if we focus on the economic benefit and impact of women's health research, that we will continue to have a greater focus on it in the current administration. So let's hope for that. And then, what was on my last one? The other thing that I think we need to focus on is that we aren't often thinking of women holistically in general. And so how do we have like a women's health checklist at midlife that all women, when they go to any kind of healthcare provider, has an opportunity to kind of have all of these things tested, baseline DEXA and, your lipids checked and all of these things that should be standard of care that aren't yet. It would be fantastic if we could kind of bring that to fruition.
I love that, and we'll work with you on that one. Charity, what makes you optimistic about the future of cardiovascular care for women?
WomenHeart champions. I mean, we're all over the country, and we represent, we are not quiet wallflowers. We come up, we show out. Just thinking about tomorrow and going on the Hill, I'm excited to see all of us in our red showing how important this matter is, not just for us, but for everyone. I love the fact that we come together in such a beautiful way to really fight for what's important for us. We can't change what our stories are anymore, but we can hopefully change the stories of those who are coming after us. So that's what really makes me excited. I also want to say that I appreciate and I'm excited about the multidisciplinary approach now to women's heart health research. I think sometimes we have seen it where it was couched as just a cardiovascular issue, but now we're seeing that everyone, different disciplines, all have a part of being a part of the solution.
I love that too. And Erin, what are you optimistic about?
They get to speak first, so
I
I can
know.
just, I can support, yeah, ditto. To see this, I mean, to see everybody in red and showing up and advocating, I think that's tremendous. I mean, I've been in this long enough to see where it was such a quiet topic that nobody talked about. And now, although I am inundated and live in this world, I feel like we are amplifying the voice.
I think so too. Thank you so much. So we've got some time for a couple questions. Does anyone?
Good morning. Thank you so much for very insightful participation. I'm Jackie Malouf. I'm the president of the Diabetes Organization and vice president of the International Diabetes Federation. So I have a comment. Thank you for mentioning diabetes as it goes hand in hand with heart conditions, and they both affect each other. They are interconnected, interrelated, as all the adjectives we can think about. My point is about the person-centered research, not even patient-centered. Let's call it a person-centered research. And what's been calling my attention is that, yes, it's very important to have the person living with a disease at the table, but also it's very important to have the carer. It can be a mother or a father. I happen to be the mother of a young lady living with type 1 diabetes, and I became an expert diabetes educator because of her, and for every other person living with type 1 diabetes. I'm not trying to divert the subject to diabetes, but I'm saying I appreciate your efforts. I appreciate the multidisciplinary approach, but let's focus more on calling it a person-centered rather than patient-centered. If you allow me, I have a comment. I was just talking about longevity in Davos at the World Economic Forum, and I said, let's be proud of our ages. Let's delete the stigma that says we women are ashamed of our age. I'm 60. I'm a grandma of 4. It's gonna be 5 grandchildren soon. It's a blessing. It's not a curse. We don't want to be the burden on the GDP. We are the productive force, right?
Yes.
Thank you.
Thank you so much. One more.
Good morning. So first, I have to give flowers to my Dr. Charity Watkins, WomenHeart champion sister. I just love you so much. And all of you, thank you so much for being here. I actually just want to focus on Claire. This is my first time meeting you, so nice to meet you. But you said something that it kind of got slipped in really quietly, the economic benefit. Please expound on that so that we all understand that women's health being optimized improves the world in an economic way, which matters a lot right now. So I just want you to expound on that.
You're absolutely right. And I think there's so many recent studies that look at unfortunately, the economic burden of women's health at midlife and beyond. And I have been shouting everywhere I can about the need for actual data that talks about what we bring to the economy. Now, there are some details that are already out there. Obviously, like public companies, those that have women on their boards do better than companies that do not have women on their boards, et cetera, et cetera. But we have to look at, I think when we're talking about how do we advocate, and when you guys are going to the Hill, unfortunately, and it doesn't matter who's in charge, I'm gonna tell you this, the economy, the economics of it is all that matters. Right. It is all that they care about. So have your data about the cost of not doing something about women's cardiovascular health, what it costs the system, and how what we're doing to advocate and to change and to prevent and to step in brings a benefit economically to the healthcare system, as well as women being powerhouses, as you just said, and at the top of our careers. That needs to be, we have to talk in that language, because doing it because it's the right thing does not matter to the people who are in charge of our healthcare.
Thank you so much, Claire. And I want to thank my amazing panelists for providing your valuable insights and reasons to be optimistic. While there is still so much work that needs to be done, the momentum around women's health is growing stronger, and together we are moving towards meaningful change. So thank you all for a great conversation.
I've asked for a moment. I'm Miriam Sharp from Savannah, Georgia, WomenHeart champion, and I'm not a wallflower either. I just wanted to just put in the air that all the comorbidities that we have often as women, heart patients, but the one area that I think especially hits home is cardio-oncology, because so many of us have experienced, whether it's breast cancer or other cancers, and I'm thrilled that Mayo and others now have that as a specialty. And I'm making a statement, not asking a question, but that any woman who's about to undergo any treatment has a consultation around that, so we protect our hearts while we're also fighting for our lives should we be diagnosed with cancer.
Thank you all so much. Thank the panel again. This was an outstanding panel. Thanks to Beth for moderating and Fiona from Amgen, and thank you for Amgen for leading us off and being a diamond sponsor of this event. We're so grateful.